So we know that breastfeeding is critical for infant health, development, and survival, and the WHO strongly recommends that in the context of universal maternal ART, mothers with HIV should breastfeed. Nevertheless, breastfeeding accounts for more than half of HIV vertical transmission across 21 priority countries, including my country, South Africa. And although breastfeeding incidence is low, it is not negligible. And in settings such as ours with high maternal HIV prevalence, the number of new HIV infant infections due to breastfeeding continues to exceed the elimination target. There are limited data from resource-limited settings on vertical transmission rates and risk factors, and such data are important to assess the effectiveness of prevention programs and to inform the choice of interventions to close remaining gaps. For the study, we used routinely collected data on mother-infant pairs in the Western Cape province of South Africa to assess vertical transmission among infants born during a 3-year period from mid-2018 to mid-2021. We had follow-up data until August 2022, which means we had between 15 and 51 months of follow-up data per child. We focused on assessing risk factors associated with breastfeeding transmission from mothers who were known with HIV at delivery. We assessed infants with HIV diagnosis at birth, 10 weeks, and older than 3 months as proxies for intrauterine, intrapartum or early breastfeeding, and late breastfeeding transmission, respectively. These time periods coincide with routine infant PCR testing of HIV-exposed infants in South Africa, which takes place at birth and 10 weeks. At the start of the study period, rapid testing was recommended at 9 and 18 months, but this changed in early 2020 to PCR testing at 6 months and rapid testing at 18 months. So our 3-year birth cohort consisted of more than 50,000 infants born to mothers known with HIV at delivery. Around half the mothers had started ART before the pregnancy, and around a quarter started during pregnancy. We classified 17% of mothers as restarting ART, which we defined as having more than 6 months of ART interruption before restarting during pregnancy. And 6% of mothers had no ART recorded during the pregnancy. More than 80% of the mothers were on NNRTI-based regimens during pregnancy, largely efavirenz-based, with smaller numbers receiving PIs or NSTIs. South Africa only started phasing in dolutegravir as first line towards the end of the study period. Of the mothers who had results available prior to delivery, 78% had viral loads less than 100, and 68% had CD4 counts above 350 closest to delivery. This cohort of 50,000 HIV-exposed babies represents nearly 20% of all the live-born babies in the province during the 3-year study period, born in public sector facilities. Overall, 90% of the mothers had a record of ever receiving ART during the pregnancy, and 94% of the infants had a record of any HIV testing, with close to 100 or 1.8% of infants overall diagnosed with HIV. If we take a closer look at the PCR testing coverage, 86% of infants were tested at birth, 67% at 10 weeks, and 48% at older than 3 months of age. But this means that at 10 weeks, a third of the infants had unverifiable HIV status, and in children older than 3 months, around a half had unverifiable HIV status. And although testing was incomplete, the median age of children at study closure was 32 months. So it is reasonable to assume that the majority of infected children would have presented with symptoms to health services by that stage and been tested. However, rate of disease progression can vary, so it is likely that we underestimated vertical transmission. For example, CPAC models projected that among surviving 5-year-old children with HIV in South Africa, the proportion in whom HIV remains undiagnosed is nearly 30%. Of the 894 infants diagnosed with HIV, 382, 146, and 366 infants were diagnosed at birth, 10 weeks, and older than 3 months, respectively. And we calculated the proportion of infants diagnosed with HIV at these different time intervals, with the denominator being those not previously testing positive and with an available test at each interval, and found that 0.9, 0.4, and 1.5% of infants who were tested were diagnosed with HIV at each interval. But apart from those 900 infants highlighted in green who were born to mothers known with HIV at delivery, there were an additional 700 infants born during the same 3-year period who were also diagnosed with HIV. 300 were born to mothers who were diagnosed with HIV after delivery, and for 400 we didn't have linked maternal data, so the timing of maternal diagnosis is unknown. The totals highlighted in yellow demonstrate that the majority of HIV diagnoses, 51%, occurs in infants older than 3 months, implying breastfeeding transmission, and that nearly 20% at least of infants diagnosed with HIV are born to mothers diagnosed with HIV after delivery. And we have very high coverage of maternal HIV testing at the first antenatal visit, so this suggests that these 20% could largely be new infections arising in mothers later in pregnancy or during breastfeeding. This graph shows age in weeks of infant diagnoses of the infants born to mothers known with HIV at delivery, shown up to 3 years of age. The green arrows at the bottom show the peaks in new diagnoses, which align with the programmatic testing that we do at birth, 10 weeks, 6 months, and 18 months. But there are also infants with new diagnoses across the ages, which tails off after around age 2. If we add the new infant diagnoses for those whose mothers were diagnosed after delivery, shown in blue, and for whom we have no maternal data, shown in grey, we can see how by age 3, the cumulative frequency changes from around 900 to 1,600 children living with HIV. And in a province with around 100,000 live births annually, that means with more than 500 new infections per 100,000 live births, we are far from achieving the elimination target of less than 50. So to assess factors associated with breastfeeding transmission specifically, we focused on the group of infants who were diagnosed after 3 months of age. But testing coverage wasn't complete at every interval, and we didn't have breastfeeding data as such. So to avoid misclassification of breastfeeding transmission in regression analyses, we only included infants who had a negative test at 10 weeks and who had an HIV result reported after 3 months of age. And we adjusted for all these factors in the analysis. This table shows the adjusted regression results of factors associated with breastfeeding transmission, and remember that this is restricted to mothers known with HIV by delivery. Nearly 18,000 infants were included, of whom 205 were diagnosed with HIV. And we found that younger maternal age, especially less than age 20, and higher parity were associated with breastfeeding transmission rates around twice as high. Maternal ART use patterns prior to delivery were associated with breastfeeding transmission. Compared to starting ART before pregnancy and having no antenatal ART gaps as the reference group, starting ART either before or during pregnancy with ART gaps of more than 2 weeks thereafter during pregnancy were associated with rates 2 and 4 times higher respectively. Starting ART less than 8 weeks before delivery, being an ART restarter in pregnancy, and receiving no antenatal ART were associated with rates 6 to 7 times higher. Maternal CD4s of 200 to 350 or unknown, and CD4 counts less than 200 were associated with transmission rates 3 and 5 times higher, respectively, compared to CD4s above 500. And breastfeeding was, of course, strongly associated with either unknown or elevated most recent maternal viral load, with viral loads above 100,000 copies per mil associated with rates 23 times higher than viral loads less than 100. So in conclusion, we found increased breastfeeding transmission was associated with younger maternal age, higher parity, inconsistent ART usage during pregnancy, lower CD4 counts, and higher viral loads. To close the gaps to achieve elimination of vertical transmission in our setting with high HIV prevalence, we need to identify and support the mothers at risk and help pregnant and breastfeeding women achieve and maintain viral suppression by providing improved access to care and enhanced social and adherent support. To reduce vertical transmission in women who are not yet known with HIV by delivery, regular HIV testing during pregnancy, at delivery, and postpartum is required, with provision of PrEP to those who test negative. And as more women initiate or switch to dolutegravir in our setting, it is hoped that future vertical transmission outcomes will improve. Compared to efavirenz, this audience will know, viral suppression with dolutegravir is twice as fast, suggesting it has the potential to reduce vertical transmission risk in mothers who initiate ART late in pregnancy especially. And in future, the long-acting agents administered during pregnancy and breastfeeding may further improve viral suppression, providing even greater benefits to both mothers and infants. I'd like to acknowledge the mothers and infants included in the study and thank my co-authors and our funders for their support. Thank you.